Decubitus ulcers are common complications associated with neurological or orthopedic conditions, primarily affecting immobilized patients. These injuries occur at bony prominences where the body contacts the bed surface. Constant mechanical pressure leads to localized ischemia, inadequate blood supply, causing tissue necrosis and cell death. These necrotic areas become breeding grounds for anaerobic bacteria, which accelerate tissue decomposition and facilitate the expansion of the lesion. Clinical progression. The condition initiates as non-blanchable erythema, superficial redness, progressing to partial thickness skin loss resembling superficial burns. Subsequently, deep tissue necrosis occurs, involving myonecrosis, muscle tissue death, and extensive cavitation, often accompanied by a foul, putrid odor due to tissue decomposition. Risk factors and prevention. The lack of specialized medical surveillance and daily wound care is the primary driver for the progression of these ulcers into extensive septic foci. Effective prophylaxis includes maintaining skin integrity through hygiene, sterilization, and moisture control. Furthermore, the use of alternating pressure air mattresses is essential to redistribute mechanical load and mitigate prolonged tissue compression. Clinical debridement and field challenges. This video demonstrates a surgical debridement of advanced pressure ulcers resulting from medical neglect in developing regions. The procedure involves the excision of necrotic and liquefied tissues until reaching viable, vascularized tissue. Notably, such procedures are being performed in a home setting, whereas they should ideally be conducted in an operating theater with a specialized surgical team and sterile equipment. Due to the severe shortage of healthcare infrastructure in these areas, these surgical interventions are performed at home using rudimentary materials. Postoperative care. Following debridement, a light dressing is applied. It is clinically recommended to reposition the patient to ensure the affected area remains offloaded, preventing recurrent pressure and promoting adequate perfusion necessary for tissue regeneration. Pharmacological recommendations and wound care intervention. To manage advanced decubitus ulcers and prevent systemic complications such as sepsis, the following pharmacological approach is recommended. A. Systemic antibiotic therapy, targeting anaerobes and gram-negatives. Since the case involves deep tissue involvement and putrid odors, systemic intervention is often necessary. Metronidazole, flagyl. Highly effective against the anaerobic bacteria responsible for tissue liquefaction and foul odors. Broad-spectrum coverage. Use of amoxicillin clavulanate or ciprofloxacin may be indicated if secondary systemic infection is suspected, pending wound culture and sensitivity (C&S) results. B. Topical antimicrobial agents. After surgical debridement, the wound bed requires topical agents to maintain a low bacterial load. Silver sulfadiazine, Silvadine, a gold standard for preventing infection in large, open necrotic wounds. Cadexomer. Iodine, useful for highly exudative wounds to reduce biofilm and bacterial colonization. Metronidazole gel, topical, specifically applied to the wound site to neutralize odor-producing bacteria. C. Enzymatic debriding agents. In cases where further surgical intervention is limited, enzymatic agents can assist in chemical debridement, collagenase ointment, e.g., Santal, to selectively digest necrotic collagen without harming healthy granulation tissue. D. Wound dressing selection. Alginate dressings for stage 3/4 ulcers with high exudate levels derived from seaweed, highly absorbent. Hydrocolloid dressings reserved for the surrounding skin to provide a moisture barrier and prevent maceration. Negative pressure, wound therapy, NPWT vacuum. If available, this is the most effective advanced modality to promote blood flow and rapid tissue approximation. E. Nutritional support, metabolic optimization. Healing cannot occur without addressing the patient's nutritional status. High-protein diet, to provide the amino acids necessary for collagen synthesis. Supplements, vitamin C, zinc sulfate, and arginine are critical cofactors for tissue regeneration and immune function. Summary of post-debridement instructions. Strict pressure offloading. The patient must be repositioned every 2 hours, Q2 hours. Aseptic technique. All dressing changes must be performed under sterile conditions to prevent cross-contamination. Site elevation. Maintain the affected area in a position that minimizes gravitational edema and maximizes perfusion.